another THCB Gang. I have failed to put the nice chart that used to be done. Things are falling apart now that Zoya Khan is no longer with me. So we're straight up with the people, with my fellow members of the gang this afternoon. We don't have, unfortunately, the fancy thing which tells you all they are, but you can see on the screen, and I'll quickly go around and introduce who we have on the show today. And of course, this is my view, may not be your view. From top round the corner we go. John Neptune, doctor, entrepreneur, head of Suntra Modern Recovery these days. Years ago, my colleague at running the Healthcare Developer Challenge at Health 2.0. Lygeia Ricciardi, these days at Carium, a hard-thrusting young technology company that one day we'll figure out what it actually does. I'm not sure what I know. I'm sure. But the consumer voice at ONC for many years, and who knows what she'll be doing in the future of that. Vince Kuraitis, long-time policy, tech, and other aficionado in the healthcare world. And Robin Farmanfarmaian, last time I will say that again, patient CEO, patient advocate, entrepreneur, running FaceTime Aware amongst many other things. And Denise Pines. So Denise, you're not quite a guest anymore because it's the second time you've been on. But last time you were on talking about femme aging. This time, we're going to lean on you with your role as a consumer advocate, president of the California State Medical Board, and also a long time producer on the Travis Smiley Show and Travis Smiley Organization. So that's the gang we have for today. We're supposed to have Dr. Maggie Carey, but she hasn't made it, so maybe she'll bust in the middle. But we're going to start the way we always start and asking people what they see. And it's been a couple of weeks since we've been on. I think since most of you have been on, it's the first time we've had some vague confirmation of who won the election, although there was the Georgia Senate runoff to go. And probably the first time since we've been sure that we've had 2 vaccines that might look like they might actually really work. So with all that, why don't we start with you, Lygeia?
Yeah, so all of that is really big news. I'm here in Washington, D.C., so I am very grateful to have the election mostly kind of settled now. I would say what I'm excited about is not only that there are a couple of vaccines on the horizon, but that the UK specifically has given a go-ahead to Pfizer. So that makes it all seem like it's not so far in the future, and it may be concrete that we're actually sort of seeing the light at the end of the tunnel. I think you're on mute, Matt.
This isn't so bad.
Matthew, you're on mute.
We can't hear you,
Matthew. We
Matthew.
gotta unmute you.
The little button on the left, bottom.
Well, Matthew, I'll back you up. So Robin, I know what he's going to say. So Robin, what are you seeing? What's interesting to you?
The vaccines. The one thing that I'm worried about, actually 2 things with it that I'm worried about. So many people want to get it up front, and then there will be a massive amount of people that don't trust it at all. And so I'm really worried about those people that don't trust it at all. Plus, fighting it out to who, for those of us who really want it. Like I'm like first in line. As soon as I can get it, I'm going to be there. Give me both doses, on the right time schedule. But it's really those vaccine anti-vaxxers. And one thing that made me really hopeful is that the 3 former presidents are going to go and take the vaccine on video. And so seeing our leaders that really led the country in a time that was not now, seeing them do that is really good.
Sounds good.
Matthew, are you still on mute?
You still muted?
This isn't so bad,
All right, so I'll go next since we were going vertically. So I think one of the last times I was on was pre-election, and we were talking about things that we might see from a Biden administration if he won. And one of the points of debate was what changes might we see to the healthcare system? And the argument that I made was that the U.S. is not really a radical change country. We fought a 10-year nuclear political war over the ACA. And I thought that the changes that we might see would be Medicare or Medicaid oriented in terms of expansions of those programs. And as you see Biden filling out his team, a very notable appointment was Neera Tanden, who has been nominated nominated to be the head of the OMB. And when she was at the Center for American Progress, developed a plan for what I saw in a couple different places was Medicare for America and Medicare Extra for All. And I think those concepts are expanding the Medicare universe, the number of people who can qualify for Medicare. And I think that having Neera Tanden come in as the head of the OMB, she's not going to be in an expressly healthcare role, but head of the OMB is an unbelievably powerful role. She is there to advocate for these kinds of concepts and obviously understands the budget landscape and what it would take to make some of these things happen. So I think that's very interesting. I think there are questions. She's already being attacked, so I think there's questions about whether she will actually be confirmed. But if she is confirmed, I think that could be very interesting from the standpoint of how we approach healthcare and what happens in terms of ACA, Medicare, Medicaid, that kind of stuff.
Fantastic, JL. Thank you for rescuing me there. I had a mouse disaster, which required going and finding a new mouse, which like I was able to do. So my brilliant mouse was working well. Not anymore. All right, fantastic. So Denise.
Yes. So I'm concerned about California right now. I'm concerned about how fast the virus is growing here. I mean, we are growing at 15,000 new cases a day, which is a 50% increase over summer. I'm concerned that our death rate is increasing at a fast rate again. And I'm concerned because we are such a large state. We have 40 million people here, and there are pockets where we're dense, and there's pockets of this state where we're not dense. I'm also concerned about the decline in hospital beds that we have, mostly due to the trend towards outpatient surgery in up and down the state, and how that concentration of shortage tends to impact the Black, Latino, and Native American communities. So that's sort of what's on my mind right now.
Yeah, I'd love to dig into that a bit because, there's some questions about what that means for the future of how we deal with hospital systems and hospital care. Vince.
Yeah.
Hey, all. I would like to make a couple of high-level observations about what I'm seeing in the telehealth and virtual care market. All good. When COVID hit, we really saw a miracle happen. And telehealth is a network technology. You've got the supply side, which is clinicians, and you've got the demand side, which is patients. And typically in a network market, that there's a chicken and an egg problem of how do you get both of these to come together at once. And because of COVID, we saw that miracle occur, and it happened all at once. And this may be a topic for further discussion by the group, but what I'm seeing is shifts in kind of the mindset of other major constituents, and I'm be curious whether others are seeing it. Doctors and clinicians initially having reservations and probably not having a lot of experience with the technology, that's changed. I'm seeing a lot of doctors, particularly specialists, really embracing the technology. On the hospital side, probably what I'm seeing is what I describe as resignation. The fear is that the revenues are lower, and it's certainly a new level of competition, but I think there's an understanding that it's becoming a price of entry, and that they're going to have to support it in the future. But the biggest change I think I'm seeing is with health plans. And before COVID, the mindset of most health plans, the biggest fear was telehealth would be additive, that it would add to costs because it was so convenient and people would use it. What we haven't seen that happen. Total visits on a national basis, and every other breakout I've seen are that visits are still below where they were pre-COVID. And so we're not seeing this additive effect. It's a substitutive effect. And I wouldn't call that definitive, but it's really persuasive. And so what I'm seeing with health plan executives is sort of a shift of mindset of, Now, maybe there's some opportunity in all this telehealth stuff here, for us to reposition ourselves versus some of the other players in the marketplace, become the virtual front door or control it. And certainly over the last number of years, we've seen many health plans, Optum's probably a prime example, where they they own a lot of physicians, or they've hired a lot of physicians. So it's not only the digital front door, but it's the physical front door for the health plan. There's still some things that have to happen. And my comments at the end will be about some of the legislation that's in the hopper. Despite, we have a lame duck Congress, I'm not necessarily real optimistic, but there's a lot going on in the telehealth virtual care space right now, and it's all really exciting stuff.
Yeah, I agree with that, Vince. There's also, some interesting, as I said, some interesting changes in the closely related remote monitoring space, and there's been some changes about that someone might know something about the ability to have patient-reported outcomes as being something that's remote monitored in the latest changes to the rules that we just put out yesterday. I have a couple of companies I'm working with in the pain space that are saying there isn't a good remote monitoring for what pain is, other than people's actual opinions. So we'll see how that plays out. But a lot of companies we know are based on sort of feeding after the those new CPT codes and following those rules. And it'll be interesting to see how this shapes out, because we're still in the fee-for-service system. All right, my note for the week is one that I stole from Dan O'Neill's Twitter feed, because he's the sort of guy who pays most attention to this. Which he noticed that Ascension, the big Catholic hospital chain, has now made it to just a fraction under 20 billion in reserves. And I was trying to remember what Apple got up to. One of my tech watches on the phone, Apple at one point got to like a cash balance of 200 billion or something. And I was wondering, if we added up all the non-profit health systems in America, do we get to like an Apple-sized cash mountain?
They've got 240 billion, so that's a lot.
We're all still getting there. They're all still getting their CARES. I think essentially she didn't take that much. Some of them paid it back, their CARES money. Meanwhile, as Denise points out, we've got some areas of the country which are still very underserved, and we've also got the issue that there are, people not in the healthcare system that's still waiting for Congress to act because they haven't done anything. Maybe something that lame duck Congress.
Hey, Matthew, I just want to highlight I had a discussion on Twitter or back and forth about Ascension. Their income for the third quarter was actually for the first quarter of their new fiscal year, which begins July 1st. They made $1.2 billion in income.
But that's mostly through stock trading, right? They're basically
it's mostly non-operating
hedge funds
income.
Which does little hospital care on the side. Not quite.
But the dynamic, I think, we're seeing it on a lot of different levels. We're seeing it, at a societal level. It's been referred to as the K-shaped recovery. Where one fork goes up, and the people who are affluent are really not hurt very much, but people of lower incomes and disparities, it's really, the COVID's really hurt. And we're seeing the same dynamic happening in the hospital marketplace. A lot of hospitals are suffering, and some are making out like fat cats.
So let's get into that a bit, because that's got a lot to do with what we think is going to happen next steps in COVID. I mean, we've remarkably, and I know the COVID task force, such as it exists, Scott Atlas, Dr. Scott Atlas, the radiologist who somehow ended up being Trump's main advisor on this. But I see Robin rolling her eyes and shrugging her shoulders on that one. Officially resigned. I didn't even know that he was an official advisor, or he was just somebody on Fox News that got listened to a lot. But we are in a term now where, as Denise mentioned, Los Angeles last night went into curfew. I don't know. Are you in the curfew zone, Denise? Are you going to be in a shot if you stand outside, if you move outside your door?
Yeah, I'm in the curfew zone. I'm in the center of Los Angeles. So
right.
Yeah.
So you're not allowed to leave your seat for the next little bit. But I mean, that's going on. We do have these massive surges. I was talking to a company today, and actually a company was in Health 2.0 for years, doing HIV reporting called Health Honor, which is now doing, it's now actually behind LA County's reporting, sort of SMS phone-based reporting of results. There's a lot going on. There's lines of cars outside Dodger Stadium and a lot of activity there in terms of, but how are we doing, Denise, on hospital beds in Los Angeles? Are we in the ICUs? Are we full?
Yeah, we are. I think we're down to that. There's about 1,000 beds left, and so that's very small. You think of Los Angeles and the amount of people that are here, that can fill up really easy. And we are just now starting to see the cases from Thanksgiving, right? We're just now starting to see those cases. But people are antsy now, right? People are like, okay, I've already done that. I've already been on lockdown. Like, I'm really ready to see my family now. It's really holiday. This is different for me now. Before, that was one thing, but now you're telling me I can't see my family. And people are really struggling with this. And I mean, even when I go out, I still see lots of people out. I still see people without masks in Los Angeles City. So I'm not talking about out in like Orange County, where it's mostly Republican and they have a different mindset. Even in the city, there are restaurants that are defining the orders. They're just absolutely saying, we don't care, we're staying open, come and drag me out, right? We're not doing this anymore. So you have people getting behind that. So, and you have, the governor like going, oh my God, I know it's going to collapse the economy again, but we have to do this because we are too large a population. And we only have so much to deal with this issue. I mean, we only have so many beds to deal with the critical. And so one of the things I've been hearing is that the doctors are now being faced with making the decision about whether or not, if this patient is so critical, they most likely won't make it, I'm not going to have them take that bed, right? This is the decision that we are now putting on doctors to make about other people's lives. And they've never really been in a position like this. So it's now starting to get really complicated. And I know, Jean, as a doctor, I know that would have to be a really difficult decision to make, to say, I'm going to give this bed to this person because this person is a little too far down the line.
Yeah, it is a very difficult thing. I mean, so I was not operating in COVID environments myself in March and April, but many of my friends were. Mm-hmm. And it was a really difficult time, right? Because as in the United States, we are accustomed to abundance. We are accustomed to anybody getting a vent when they need to get a vent. And I was talking to a friend of mine who is at Maimonides Hospital, which is in Brooklyn. And they got close many times to being in a position where they had to tell patients, we do not have a vent for you. Fortunately, we have a lot of resources here in New York. So I think that those kinds of decisions in New York were not common decisions, and doctors fortunately didn't have to face them here. But in rural environments, right, in towns, I was reading about the Sun Valley, Idaho, where a lot of New Yorkers have decamped to, and apparently Sun Valley Hospital has like 4 ICU beds and 4 vents or something like that. In rural places where they are resource constrained, those are decisions that doctors are going to have to make. And we are not accustomed to making those types of decisions, either as providers or as patients. And I think that's, of the many traumas that are going to emerge out of this pandemic, that is going to be one of them. And, people forget that doctors and nurses and respiratory techs are people who go to work every day and love the work that they're doing, and they're getting traumatized at work. And, the hope is vaccine soon, get this over with, and hopefully try to get back to some normalcy, because we cannot persist in this environment. This is unsustainable.
I think a lot about this burnout issue and the fact that many providers were already somewhat overstrained and overstretched pre-COVID, and now they're having to work in an extremely overwhelming, dangerous work environment day in, day out, and on top of that, make decisions like that. And I'm afraid you're just going to see sky high roofs, levels of just like overwhelm among this population, which of course then is like a negative cycle because you have fewer people to deal with all the influx of patients. And to Denise's point, I mean, we're in the holiday season. Thanksgiving was one thing, but now we've got Christmas and New Year's coming up pretty darn soon. And I think we're not going to be really through this until we've gone a few weeks past that. And then hopefully we'll be on the upswing.
So, I mean, I would say that, you know, we talk about like getting the vaccine, right? As you mentioned, Lygeia, the Brits approved it based on assumed intensive study, although they don't have to be ruled by the European Union's drugs thing anymore, so they probably made it up as they went along there in the current British government, but I'll leave that aside. But you know, assuming that we get an emergency use authorization out of the FDA, you know, sometime in the next week and a half, which sounds likely to have, we're going to have the same issue here. There's a bunch of issues around, you know, the refrigeration and who's going to be in charge of it and whether we're ready for the kind of mass distribution and who's going to manage it, whether it can be managed. But, you know, we should take a second to go, what an amazing miracle of science has been that we went from, you know, figuring out what the disease was to a vaccine within a year, whereas HIV, it's been how many? 30 years, we still haven't done it. But having said that, we're still, as Denise pointed out, we're still sitting here with, you know, these rates going up. And it seems to me that there was a hotspot. You know, there was New York, there was the South, now it's everywhere. And if California, I mean, maybe Northern California isn't so bad, but if Southern California is going to become a hotspot around the beds, what do we think the next few months, because realistically, we're not going to get vaccines out broadly within a few months, but the next few months through to sort of, you know, February, March, what are they going to look like for the healthcare system? You know, are we literally going to be doing the triage thing that Denise talked about, turning people away? We are seeing already apparently lower rates of hospitalization than we were seeing earlier in the year. Is everyone have thoughts about that?
I'll comment as a physician in the room. I think we're going to see the highest highs of the pandemic over the next few weeks and months, right? At the end of the day, I think people have pandemic fatigue. As Denise mentioned, you know, I think here in New York, we're better in terms of masks, but I think that people are getting sloppy. You know, my mother is 82 years old. There was, at the beginning of the pandemic, I didn't even see my mother at all, right? For weeks and months. We've gotten a little bit more comfortable. And I think that as people try to have some normalcy, try to have a normal Thanksgiving, despite what the CDC says, and tries to have a normal Christmas, this virus takes advantage of human behavior, right? This virus has evolved to do this. And I think that precisely as Denise said, right? Thanksgiving is the initial inoculation of a large part of the population. There's going to be another huge inoculation between Hanukkah, Kwanzaa, Christmas, all those celebrations. And then essentially what you see is 4 to 6 weeks after that, you start seeing your peaks in terms of hospitalizations and deaths. So if you think about a timeline, I think things will be the worst that we're going to see them end of January, beginning of February ballpark. Now, if we can start getting people vaccinated in January, then maybe we may be able to attenuate some of those peaks. But I think that in terms of, you know, you look at the news in March, the news was New York and Seattle, right? Or whatever it was. Now it's basically every state. If you watch the nightly news, every state is reporting this. Every state is reporting maxing out of the healthcare system. And it's not just hospitals, right? It's ambulances, it's the private doctors' offices, it's every element of the healthcare system is being taxed. And again, I think what we're going to be exposed to is an environment where people are accustomed to abundance. They're accustomed to getting whatever they want, whenever they want. And they're going to be discovering that in the setting of a pandemic, a lot of that goes away.
Yeah, I mean, I've been thinking about that. I mean, but that leads us through to essentially, you know, February and maybe even March being very bad times, right? You're talking about maybe 2 to 3. And we're talking, it's been going, you know, it was 50,000 a day, then it got 100,000. It's kind of 200,000 a day. It was, you know, up to 1,000 deaths. It's going to be 2,000 deaths a day, probably 3 and 4. I mean, we don't, you know, those slopes. And it probably also means that we're going to see complete overrun of the hospital system. So we just did this Robert Johnson Foundation challenge back before Christmas, Thanksgiving. I got my holidays all mixed up now. Where we had a bunch of tools for you know, particular reactions to the pandemic. And one of them was there's a company called Cuventus, which is one of these startups that's got good amount of money from Silicon Valley to VCs to do sort of analytic tools for hospitals. And one of the things they were showing, and actually won the hospital system side of this, was a base of scenario planning tools for showing you where you ran out of ICU beds based on local things like were people wearing masks, what was the time of year, what was the weather like, are people going indoors, are restaurants open, what is, all that kind of stuff. And they ran through a bunch of scenarios and none of them were good, right? Most of them involved a couple of things. One is running out of ICU beds, just the norm. And the others were having to close back down, even though there was this kind of dual idea of running a COVID hospital and running elective surgery separately, having to close back down a lot of that elective surgery, which was the issue that we had with the health system, in terms of funding the health system back in March, April, and May and June. So it showed to me that if you think about the consequences, it's like back to where maybe New York was or Seattle was or Houston was. I think we've got a very bad few months in many ways to come. And don't forget, in the middle of this, right, January the 20th, we have a new team finally takes over. So is there something?
And Matthew, by the way, there were 2,700 deaths in the United States yesterday because of COVID.
So
2,700.
So that, annualize that out, we're expecting now, we were running at what's the total now for the whole pandemic?
250 plus,
50 plus.
Yeah.
I mean, but you go through another 30 days of that, you're at 300, and it's also going up, creeping exponentially. So do we think that this, other than the vaccine, right, which, by the way, don't forget, you have one shot and then it's either 3 or 4 weeks later to have the next shot. Is that right, Robin?
Yep. Both of them have 2 doses, I believe.
And then you have to wait how long till it works after the second dose? Do we know, like another couple of weeks?
Well, the first dose will offer some immunity, right? So it starts the process. It's the second dose that will bring it up to that 90 or 95% effectiveness that we all want. But you will be partially covered with that first dose. And we do this with Hep B, right? We do this with a lot of vaccinations.
Yeah. But it does, even just, so getting the vaccine out all sounds great. And maybe we start in the late part of December with, frontline healthcare workers and people in nursing homes and what have you. But I mean, we're still talking about a long way from getting, and then there's a month, right? So you start and it's a month before you are really covered. So we're still talking about a long, the concept that JL's talking about having a big national surge, really, which we'll see in late January, early February. We're a long way from the vaccine really being able to eat into that, or am I being too pessimistic?
I'm guessing April, May is when we'll see the turn, right? Everything is going to accelerate up until then.
Yeah, I just don't think they're going to be able to distribute. So remember, they've got to approve. The vaccines have to have final approval. They have to be produced in scalable quantities, and then they have to be distributed to the delivery system, right? And then people have to sign up and actually get them. So I think you will have some people who get vaccinated in January, like right after it's approved. But I very much agree with Robin. We'll probably be, past some very, very scary peak before you can start to vaccinate large numbers of people.
And don't forget, we have a lot of people, right? So, ignore the vaccine for the moment, and it coming out, where, you talk about a few thousand deaths a day. There are obviously thousands of deaths a day anyway in the US. But we're talking about, I read somewhere, New York Times estimated that we were at 350,000 excess deaths above what we would have expected by this point. And, that sounds like it's heading to 500,000, 600,000 by the time we're through this, maybe more, right? Maybe. So not 1918 levels, but pretty bad, So I'm just wondering, let's go back to Denise's sort of question that she started with, okay, we've had a healthcare system where for years hospitals have been very expensive, and we're trying to encourage people not to go into hospitals and doing outpatient surgery and all that, and we talked a lot about doing chronic care management at home. And Robin, you were right in the middle of this whole thing about and all the telehealth stuff Vince came about. Do we think that, and I said we have this new team coming in, do we think we're going to have a significant change in our philosophy around that? Or are we just going to say this was a blip and we dealt with it?
No, I think we're gonna have a change. I don't think you can have something like this and not really have a change. I think all healthcare is analyzing themselves. They're analyzing their IT systems, right? Because some facilities, hospitals, doctors' offices weren't up to code just with IT and integration. So some of those who were able to respond really fast had good IT, right? And they were able to use that IT to do the kind of scheduling you need to do. So I think everybody's evaluating, what was my technology in this, right? What was my people power in this, right? Who were real leaders and who weren't real leaders, who we thought were leaders and who were real leaders, who had courage. I mean, let's be honest. There are some people who said, I don't want to get involved. I don't want to touch the patients. So we're gonna see so many and hear so many different stories. We're also going to see what crime came out of this, right? We have, complaints already, almost over 600 complaints from the public about telehealth and how that's being used, about prescriptions that they didn't say that they asked for. So we're going to see what crime has come out of this. And of course, we're going to see, who were the losers in this. We've already got early signs of that being people of color, but who else were the losers? We see in this state that the Filipino nurse population has been most impacted when we look at nurses. 70% of the deaths of nurses have been Filipinos. So we're going to have lots of analysis around this pandemic and our readiness or lack of readiness in so many different areas. It's gonna be a fascinating study down the road. Right now, we're so in it, right? But the kind of conversation you're gonna have a year from now is gonna be really, really interesting.
Matthew, I can comment a little bit from our neck of the woods, and Vince sort of triggered me into thinking about this when he did his intro. For in many ways, medicine in this country has been defined as an in-person practice, right? Everything is in person. Everybody's got to go to the doctor. They got to schlep to the doctor, take time off of work. And for a long time, it was very difficult to dislodge that concept, right? And in my universe, as you know, we provide addiction support services to people who are in recovery. So what we do is we give people medication to help them deal with opiate addiction, alcohol addiction. In our world, there's a process called induction. When somebody starts on, somebody who's using opiates starts on a drug called buprenorphine or Suboxone, the beginning of that process is called induction, right? And there can be some risks associated with it. So in the past, we always said, hey, you have to do those inductions in person in a doctor's office and somebody has to see you. What's come out of this pandemic is that people have discovered, home induction is actually pretty safe. And as long as you're in good contact with the patient, you use video, you're checking in with them, home induction is safe. So it's fundamentally changing the practice of medicine. Another example is we do alcohol detoxes, right? So sometimes when people are drinking a lot and they want to stop drinking, they have to be observed, right? Because they can go into DTs. There are a bunch of complications associated with the acute cessation of alcohol. That was another thing that people said, you either have to do in an inpatient environment or an outpatient environment. You can't do it at home. But more evidence has accumulated, it existed before, that for a certain subpopulation of patients, at-home detox is actually quite safe. So I think what's happening here is not only are we discovering that telemedicine is a tool that we can use to support patients when they can't get to a provider, but actually a lot of the things that we thought that patients needed to be in the presence of a provider for are not needed, right? Now, the question is, how is that codified in terms of how we reimburse providers? That's the big question, right? Because if doctors at the end of the day are like hamsters on a wheel. If the cheese is in front of you and you have to provide care in an in-person environment, you'll just stay on that treadmill. But if the payers, and hopefully with the government, Medicare, Medicaid being the lead payers, saying we can practice medicine in different ways, I think you're going to see a fundamental change in at least many areas where we used to think that in-person care was critical, but there are alternatives that are available.
Yeah, I'd love to get Lygeia to come in on this because of what you're doing at Carium. I'll give you two. I just interviewed Glenn Tillman, formerly of Livongo, and now on the board of Teladoc after that big merger, about that. And he for a conference I'm doing in Japan. I'm supposed to be in Japan next week, eating sushi, having ramen, drinking whiskey late at night, and
Wait, without me this time?
Without me this time too, Robin. But Robin and I have been in Japan together, and we've done the excess ramen. But what he said was quite interesting, which was that Teladoc's numbers are now showing that about 60 to 70% of the visits. You always thought of Teladoc as my kid has a rash, or I have a cold, or whatever. Sometimes 60 to 70% of the visits now are from people with chronic illness. So in other words, sick people are using the system because because they're the ones who use it, and it's looking much more normal rather than this being like a replacement just for urgent care. But I wanted to come back to one thing, and I love your comments on this, Lygeia, about well, actually, why don't we just go, Lygeia? Tell us a bit about what Carium's doing and how you're working, because you're kind of in that interface between.
We're in that space where we do telehealth care. We're a platform, but we're not primarily focused like some others on video. We do enable video, but it's this idea of a connection between a patient and a provider from a distance and at home. And I think what we're seeing, and a way to think about this, is not just, okay, patients no longer have to stop what they're doing, take a day off work, whatever, take their kid out of school to go in physically to have an appointment. It's not just, oh, we can replace that, but technology can actually help us to enhance what we know about that patient and get a fuller vision of their health on a day-to-day basis. It's even more holistic. So what we do is we do things like remote patient monitoring. We can plug in all kinds of digital devices, ranging from things that will track, blood pressure or glucose levels or steps or thermometers or pretty much anything you want to attach to our platform. But the point is, if you have an ongoing feed of those things and you have a system, which ours does, which allows you to set thresholds so you can see, oh, people are, getting into a risk area for one measure or another, you can then proactively reach out to someone before you have an issue. And that's a fundamentally different kind of care. That's care kind of embedded in daily life, which is, again, not just this substitute for something else that may be easier for the patient, but it's like much more holistic and I think effective model of care over the long term. Again, payment models are still catching up to that, and we see some progress in that in the RPM realm in particular. But if we can shift payment models so that we're doing more sort of ongoing maintenance care and sort of spotting issues before they come up and preventing them, that's how we're going to see, I think, really better outcomes, as well as get payment issues, costs out under control.
And Lygeia,
I'd like to hop in if I may.
Sorry, yeah, please drive in.
Yeah, so I'm seeing a divergence among, picking up what John Luke and you're saying, Matthew, a divergence among the telehealth players. I'll use Amwell and Teladoc as an example, but I think they're just representative. I think Amwell's model, recently heard Dr. Roy Schoenberg, one of the co-leaders of the company, co-president, I think is his title, say, we're a technology company. And I think Amwell really sees their role as supporting local healthcare providers, providing a platform. And yes, they had to get into providing visits, but he doesn't see that as their main business. And it's probably a commodity, low margin. So I can see why it's not a very attractive visit. I've seen telehealth companies now giving away free visits just to get people in the door. And in contrast, what I'm seeing is, you look at Teladoc and Livongo, and particularly the capabilities that Livongo is bringing, is their mindset is much more not to support the local delivery system, but to take over the care and to do it virtually. And, it's kind of back to the old, you'll remember this, Matthew, from the disease management days. It's the carve out versus carve in model. And the market is plenty big enough, I think, probably for both to be very successful. But, they're very different approaches, and it's not clear to me at all which one's going to be, better, and they may coexist.
Yeah, I mean, that's a really interesting question, Vince. And I will say we at Carium think about both sides of this, in that some of the healthcare organizations we work with provide their own staff, and we are a platform that enables them to do what they're doing. In other cases, we don't hire directly, but we work with other companies that provide staff who want to augment their, say, nursing team or what have you. And I don't know, as you say, both models may coexist. But I think about the way we think about our value is helping organizations through more healthcare transformation. In other words, not just doing the care that you were already doing, but changing to a much more patient-centric model that ultimately is going to set you up for success in value-based care, because you have to have the patient engaged in their care on a daily basis and changing behaviors if you're really going to impact health.
So a couple of weeks ago, I gave a keynote at the Big Chime conference, that's for hospital CTOs and CIOs. And I really talked about both the shift in healthcare delivery into the patient's home, but integrating some of these things like you're talking about, Amwell being that platform, which is why Samsung and Philips invested in them. Livongo's, I don't see them as telemedicine necessarily, as more as chronic disease management, right? Because they're in the patient's daily life and they integrate into the HIPAA compliant Amazon Alexa. So it even brings that patient voice into it, and it creates that big feedback loop. So these are very different things. But one of the things that came out of this keynote, I got to talk to a lot of hospital CTOs. They said, okay, well, are you shifting, IV medications into the home? United is forcing all, things like Remicade, which is what I'm on, into the home, and they will not pay for it anymore, done in hospitals. And Humana and CMS are both making a really big push for dialysis to be done in the home. And I asked them, I said, are you even looking at things like a portable dialysis unit out of UTSET, right? And I'm hiring those nurses that can go in and give patients their dialysis. He's like, Robin, we had the hardest time just doing things like telemedicine because of our IT infrastructure. There's no way to plug in something like at-home dialysis. Would actually take a huge amount of money and time to do the electronics right behind it. And I'm like, that seems a little bit odd to me, but I mean, like backwards to me, because this way we don't have those patients in the home. But I think that is one thing that is going to stick, because we are seeing those payers shifting that in-person care, sending that doctor. Like United sends a doctor to a patient's home once a year for free for an annual checkup, right? So really doing that.
Got it. And just to follow up on a couple of points from everybody who's spoken, I think, let me make a statement. One of the beauties of getting older is you start seeing the field, right? Things start to cycle. So, in the time that I worked together with Matthew at Health 2.0, the digital health was cool technology that we're going to sell to some provider to fundamentally change the way they operate, right? So if you think about the big names, ZocDoc, Phreesia, those kinds of companies. But I think what you're seeing in, let's say, the Health 3.0 realm is companies realizing that if you really want to create value, going back to what Lygeia was saying, is you not only have to control the technology, but you have to control the delivery to some extent, right? Whether it's a bit of the delivery or the whole thing. So I think what you're seeing in the Health 3.0 world is very large fundraisers from companies that are trying to own whole silos, right? And they're trying to own not only the technology, but the process, the people, and they're really trying to deliver a full stack service. So, that term has been around for a long time of, full stack startups. But I definitely think in healthcare, like the direction that we're moving is much bigger raises, much more comprehensive offering top to bottom, because I think people realize you can't take a turbocharger and put it on an old horse and carriage, right? That won't work. You've got to create a whole new car, whole new engine, whole new driver to really make change and to really deliver care effectively.
Lygeia, Carium is kind of on that side of working with the current set of providers, more so than and helping them.
Yeah.
And look, it's going to have to be both, right? But I mean,
have to be both.
But nonetheless, there is, we've gone through this a number of times. If you go back to what I said about Ascension earlier, and we were joking about the Apple Cash Mountain, and if you add up Ascension, UPMC, and Sutter, and whomever else, right. My one joke for the whole thing is that Rock Health is out with its top 50 in digital health, and you get to vote for that. And non-profit of the year, I can't remember who the other one was, but Sutter Health was one of them. I'm going, this is the non-profit that got fined 575 million for overcharging this year. Now it's becoming, I think it's going to be non-profit of the year, maybe. But we've seen nobody has gone broke. Hang on, do I get this right? No one has made money overestimating the speed at which the American healthcare system wants to change, right? So did I get that right? I think right. So and I understand selling stuff to current incumbents versus trying to raise a huge $200 million or whatever the numbers are for some of these companies. I mean, Verta has now raised 400 million worth of billion to do just one slice of diabetes care. Give me a sense about what you're hearing, what Carium's hearing, and when you're out there in terms of the speed of this change.
It's interesting because you've got, on the one hand, as we've discussed earlier in this conversation, massive change, even within a period of a few weeks of people like not using telehealth type services and then boom, adopting them. So you've got huge technological, switches in the way people do things. But in terms of sort of long-term moves toward, for instance, value-based care, I worry that in some ways this whole pandemic has slowed down that process because people are just in crisis mode. For a while it was, and it is now again with this surge, how am I going to deal with this influx of patients and the overwhelm of my staff, looking at a provider perspective. But then also the economic impact. I mean, to your point, there are a lot of organizations that are doing really well in healthcare, but there are many, particularly some of the smaller ones, the mid-size providers and not the sort of top players in the hospital system world, who are really struggling financially. And so they're kind of just getting by and figuring it out. And so I think we've slowed down systemic change in some ways. And I worry about that. And I will also say, sort of as a young company, it is sort of selling into systems. It's a ridiculously long sales cycle. It takes such a long time. It's like easily 18 months. Like Carium's not that much older than 18 months. It took us a while to, I feel like we've made massive progress getting into, St. Luke's and a bunch of other huge systems like in a short period, but it's really hard and it's difficult to do innovative stuff and sell it really quickly. So that's sort of a challenge to the speed at which at least new technology companies anyway can enter and add to this picture. And I worry super big picture that in some ways, both socially and on a business scale, COVID is helping those who are already ahead, like zoom ahead, and those who were not are sort of getting pulled back. And I really mean that on many levels of society. And I don't think that that's good, not only for the people at the bottom, is it obviously bad, but it's also bad for us as a whole because we need that diversity and on a business side, we need smaller businesses, startups, all this kind of thing to kind of drive innovation.
Lygeia, you ask or wonder whether this is all going to slow down value-based care, and I've heard it argued both ways.
What do you think, Vince?
Well, I think it'll speed it up, but I think there's, but I think what I'm missing and what I'm looking for, the argument that it speeds up value-based care is what hospitals have experienced and providers have experienced is without fee for service and the volume goes down, you lose all your revenue and your expenses continue. What I'm not seeing though is announcements of health systems and payers saying, well, we've renegotiated our deal. It's going to work better for everybody. So I think, again, it's probably going to be some of both, depending upon the marketplace. The U.S. health system is not at all uniform. It's very regionally biased. And my take has been, even pre-COVID, maybe 25% of health systems sort of really got this value-based care thing. And, the incentives are mixed, even for payers. Their revenues are largely driven as a percentage of revenue. And so the health plan, has to go through this thinking of, if I lower costs, that could be lowering my revenues too. So, I think ultimately it will come out, we're going to see more value-based care, but it's a real question in my mind. And it is, to me, the central question that I'm watching. I mean, for me, 30 years in healthcare, Econ 101 explains more of healthcare to me than anything else I know. It's follow the money, unfortunately, but that's my reality.
Right. And then we also have the regulation, right? We always have to look at how all of this is regulated, how doctors are regulated. That's what I deal with. And even with telehealth right now, just in the state of California, I can't speak to the other states, even though I talk with them. In the state of California right now, we've laxed our or waive certain types of requirements we would typically have around telehealth, and they're connected only to the governor's executive order. As soon as there's no longer a pandemic, as soon as the governor says we're out of the crisis, we go back, which means legislation will have to be put in place to change that for everybody who's operating telehealth the way they have been, right? And so right now, I haven't seen anything from any of our legislators come forth. The only thing that I've seen in particular is around pharmacy and the pharmacies having the ability to be able to implement the vaccine, right? Because that's not just a given that they get to give this vaccine out. And so that's the only new regulation that I've seen that, of course, we know is going to pass specifically. But what, everyone tries to do, everyone's going to lobby the way they want to lobby it. And the way they lobbied in our state is they try to say, we can use it, we can do any vaccine. And that's not what they're going to have the right to do. And so they almost lost this bill. Well, we asked them to change the bill, but they almost lost this bill because they wanted to do something. They went macro, right? As opposed to stay focused. We're in a pandemic. Nobody's sleeping at the wheel, right? Definitely not the regulators. So we're also going to have to juxtapose all of this, IT growth and how everyone's trying to use it with the regulations that currently exist in every state.
I think you describe really the whole, not you spoke for California, Denise, but what you describe, it fits the rest of the country as well. And, my summary would be in the absence over the next couple of months of regulatory and legislative changes, the default of what's going to happen to telehealth for the large part is we're going to go back to the old normal. And because we go back to the old legislative regulatory structure and reimbursement mechanisms. This week's CMS, SEMA Verma announced, I think CMS has really actually been very supportive of the whole process. They've bent over backwards, but she acknowledged their lack of legislative authority. And the example she pointed to, we've given all these new services that CMS will continue to reimburse, but only on a rural basis, and that it will not connect with the patient's home. There won't be anything that we can reimburse where the site of care is the patient's home. Well, boy, is that a deal killer. I mean, but it's the reality. It's things, and that's where I think watching legislation over the next couple of months becomes really, really important.
Yeah, I did notice in that, just before I jump in, Robin, did notice that in that ruling by Verma, there was at one point you could charge for a phone call, a straight phone call, which obviously works, and easier for doing. That got pulled out, and you're right. There's little background here, and it kind of makes sense with the world of value-based care, but most American healthcare is paid for out of that CPT code system, and you've got to have the right CPT codes, and everyone's got to agree to pay, and it's gonna be complex, especially when as Denise says, one day we'll be out of this pandemic, and maybe it's sooner rather than later. Robin, I interrupted you.
So I think that, yes, the regulations will go back and then we have to, change the legislature, but I think patients are going to demand it. See, the thing is with patients, and I hear this with a lot of patients who have eventually moved their IV medications into the home, we're terrified at first. We're like, wait, no, we want to be where the doctor is. We want to be where all the life-saving equipment is, and then we try it. And we do the IV medication in the home, or we do telemedicine, or we just take care of something with a simple email to our doctors, and it clicks. And we're like, wait a second, that was 10 times easier and much more enjoyable to be able to do it that way. And so we're going to see a lot of patients not wanting to go back to just having to go into the hospital.
I think a lot of this is going to be split by age. What I'm seeing is younger generation, Z millennials, telehealth is a convenience, and they're even willing to pay extra for it because it's so convenient. They don't use it a lot. Seniors tend to prefer to see their own doctor. Habits are hard to break.
We'll see about that. I wonder how much that is. It's like the social fun of going out to the doctor.
I'm speaking generalities here.
But a and it's going to play out. And of course, don't forget, if we're back in second, third wave, whatever. A lot of this stuff is going to have to, by definition, go back to the way we were. When we go back to our discussion 20 minutes ago, we're talking about no ICU beds available in large parts of the country. We're talking about, locking down. We're talking about those elective surgeries and those elective visits that were picking up, closing down again. And, Denise is not allowed to leave her house, right? may not be allowed out till April. I do know that my friends in the UK, who are now been locked down twice, are all lined up. The pub is back open up again now, and they're all out there. They're back at soccer matches and whatever this week. So things are, they sort of go in and out. California's been much more sort of semi-shut down the whole time while I've been here. But we've got a way to go, and it's still going to impact on this. So I don't think we're going to be losing those emergency regulations, but. And we haven't had a chance to talk about it today. Maybe that's what in the last 3 minutes is we do have a new administration coming in federally, right? Which is going to start on January the 20th. They've said many times Biden said many times, what is, some happy people on the phone here. Have people on the line here. But Biden said many times, what is their first priority, right? It's sorting out the COVID crisis, right? And this is part of it. So. All right. Well, we're very close to time. So, and I want to thank particularly JL for taking over the bit when my mouse collapsed and I could no longer be the MC. It was clear I was here but couldn't do anything. And thank you guys for self-regulating and self-organizing in good anarcho-syndicalist fashion for the opening there. Let's do the close now. And I just want to go around and say, what are you guys looking for? Expect to happen? What do you got your eye on for the next couple of weeks in the run up to Christmas? So, JL, we'll start with you.
I just hope we can get a stimulus bill going, and I hope we can reach compromise and, break this paralysis. People are, I think it was Lygeia who said it, there is a top level of people who are educated, who got jobs that they can work from home. They're doing great, right? But there are tens of millions of Americans who are suffering, who need relief, who need our help. And if we don't help them, we hurt the people at the top anyway, right? Because if the people at the bottom can't buy what they need, then the people at the top don't benefit. So I think we got to find compromise, figure out a way to help people, stop being ideological, figure out how to make it work. That's what I want. That's what I want for Christmas.
Is that going to happen before Christmas? Or we have to wait till?
I don't know. I saw a tweet from Speaker Pelosi today, and it seems like they're moving forward. I mean, obviously the White House is a wild card in all this, but I think, there's a chance before Christmas. I hope.
Vince.
I'll flag a couple things to look for. As I mentioned, there's a number of bills in the hopper that are in the lame duck session of Congress and may come back. The good news is telehealth and virtual care really is bipartisan. What to look for? I'll flag a few things. One is, will it allow for visits to occur in the home? And as I mentioned, the default for Medicare is to go back to a situation where, except in rural areas, that's not going to be allowed. And secondly, the cross-state licensure. Will Congress pass something, or will it require states to join compacts? And the third thing I think to look for is the scope of practice. Is it going to be narrow and require physicians, or will it allow broader participation beyond physicians, nurse practitioners, PAs, PT, OT, different kinds of therapies? I'm optimistic, but lame duck sessions don't usually produce a lot.
Lygeia.
Immediate term, I'm hoping for a stimulus bill. Slightly longer term, as we get a new administration in, I am hoping for a process of healing, rebuilding trust, closing the gaps across political extreme divides, and rebuilding a society in which I hope there is more trust and support for scientific evidence.
Hallelujah.
Hallelujah. Well, I don't feel about happening by Christmas. Denise.
I'm looking at something here in California. So the U.S. Supreme Court struck down New York's restrictions on indoor religious gatherings. And we now, tomorrow, I think it's going to be decided here in Pasadena, California, whether or not our Supreme Court will do the same thing. I think that large church gatherings are definitely not something that we should be doing. There are ways that you can still participate in church, which is online and going into the the garages, the driveways, whatever. I think that and especially Christmas, that's a critical time. Hanukkah, that's a critical time. So I'm hoping that doesn't change for our state. And then I think long term is really what's happening with our schools and the students and student learning and the data that has come out about the failing students across the country.
Robin.
So I'm just focused on the vaccines. I'm an early stage pharma person, and I'm a huge vaccine proponent. I've had a flu shot every single year of my life. And I'm really looking forward to this. So the one resource I follow to find out what maybe the distribution is Dr. Bob Watcher at UCSF. He has a fantastic Twitter feed. He's got some great graphs up there on when he expects things to be distributed.
Yeah, I think we're living. I was always told when I was at Institute for the Future with Ian Morrison, and many of you been on with Ian on this show. He always said that the joke is right. Plan for the future, but don't live in the future before we get there. Our future's a little. I thought it was going to be years away, so I'm very happy that it looks like these have been so successful, these trials, but these vaccines are coming out. But it's still going to be a brutal few months. And as we remarked here, we're kind of close to the threshold of blowing the pot. We were talking about flattening the curve, and we flattened it for a while, and it's now running in all the wrong directions. So I think we have a very interesting few months, and the fact that we have a transition administration during this is going to. Not to mention the holidays and all the gatherings that Denise is talking about, religious and others. Even the Premier League is now letting fans back into the game starting this Saturday in some parts of the UK. To me, I think we are facing a very, very interesting, somewhat frightening few months here. And I am not unconcerned. At least the election went the way most of us wanted it to go, but I am, and people and professionals are coming back in many areas. I mentioned near Tandon right at the start of this, but I remain concerned about what's going to happen the next few weeks. And I still, the healing that Lygeia talked about, it's not coming by Christmas, I'll tell you that much. Anyway, all right, that's my pessimistic end. We've gone a little over time. I want to thank my guests on this episode of THCB Gang, John and Neptune from New York, Vince Kuraitis from the Wilds of Idaho, Robin Farmanfarmaian from Palo Alto, California, Ricciardi from, one day I'll get your name right, Lygeia. Ricciardi from Washington, D.C., and Denise Pines from the new Colditz Castle lockdown camp. What was Hogan's Heroes? of Los Angeles. Hope you'll be let out one day. That's it. Matthew Holt wrapping the healthcare blogs THCB Gang for today. Bye now.